If you have a breast cancer, the 5-year mortality rate is 9%. Whereas for the patient with diabetic foot ulcer, it is 30%. And for even with minor amputation, the 5-year mortality rate at 46.2, and with a major amputation, the 5-year mortality rate is 56.6. So that disparity, that too much effort on cancer side is great. That's great. Okay. But what is being done for diabetic foot? Or forget about diabetic foot. What is being done for metabolic ill health? Why are we not even thinking that disease processes are driven by metabolic fitness of each person at a time?
Welcome to At the Helm, the podcast where we explore food as treatment for chronic disease. I'm your host, Dr. Charles Helm, and I'm honored to be broadcasting today from the traditional territories of the Treaty 8 First Nations in the foothills of the Rocky Mountains in Canada, northeastern British Columbia, from the community of Tumbler Ridge. I am a family physician. I'm also a paleontologist. I'm fascinated by evolutionary biology, fascinated by how we got from where we were about a century ago with our health to where we are today and what the causes of that might be. And today, once again, we're going to be talking about type 2 diabetes, but from a different perspective. It'll be from the perspective of non-healing wounds and the terrible toll that this takes in the form of limb amputations. There's some astonishing statistics. In North America alone, more than 165,000 people have lower limbs amputated every year due to diabetes. And the life expectancy following such an amputation is maybe 5 years on average. Chances of a second amputation, maybe 1 in 3 people need that. So we tend to think of limb amputations being the result of war accidents, car accidents, things like that. But the horrible reality is that 80% of these amputations are the results of type 2 diabetes. So my guest today is Dr. Ravi Kamepalli. And Dr. Kamepalli knows all about this because he's one of the few wound specialist doctors in the USA who is treating these non-healing diabetic wounds with low-carb diets and ketogenic diets. He's got over 24 years of clinical experience. He's a board-certified infectious disease specialist, certified wound specialist with a diploma in obesity medicine, and he's a certified metabolic health practitioner. He provides clinical services in the cities of LaGrange and Newnan in Georgia, and he's currently an associate professor at the Mercer University School of Medicine in Georgia. Now, Dr. Kamepalli has said that preventing amputations, healing wounds, improving metabolic health with low-carb diets is not just a passion, but an obsession for him. So we are going to delve into that obsession today. Welcome, Dr. Kamepalli. You're so welcome to join us today. Thank you for joining us. May I call you Ravi?
Yeah, please. No problem. Thank you.
Yeah, no, thank you. It's wonderful to have you with us. So it's quite an intriguing combination of areas of expertise that you have: infectious disease specialist, wound specialist, metabolic health. It's unusual, I think, for in a physician. And so I'm just really intrigued to find out from you what led you to enter that field and specialize in these, what some people might think they were quite diverse areas.
Yeah. I mean, I go to mostly to the challenges that I face. And number one, I came to India from a small town called Guntur, which is one of the premier institutions in southern India for medical teaching. And most doctors who come try to do cardiology and all like that. I initially thought that's what I want, but ended up doing internal medicine and infectious disease because I did not know anything about antibiotics. So that was the not knowing thing that made me go towards that. And from there, I got into wound care because I did not know it. And then, as I was infectious disease wound care doctor, I saw this revolving door of healthcare problems of my infection and wounded patients, and found that I'm not really solving the problem because my office had become a revolving door, and I work hard to save their feet, but they come back in 3 to 6 months again. And found out that I have, during this whole journey of 20 years after becoming a medical doctor, I ended up noticing that, hey, I'm myself having my own metabolic health problem with obesity. And I ended up having a tragedy in the family with my mother having intracranial bleed. And I started trying to understand why intracranial bleeds happen. And lipoprotein little a was one of the molecule that I found is a pseudo marker. And luckily, it so happened that I took my mother's blood and my blood and my cousin's blood, and ended up finding that I have something called as eNOS mutation, and that is related to how lipoprotein and all those things are happening. And so, just wanted and I said, what am I doing? I don't even pay attention to lipid system. So that opened up this whole concept of my thinking, which is seeing you're seeing in my background. And so if you're seeing that in healthcare, the top triangle is what is most people are taught as. You're taught that genes are there, environment is there, and lifestyle is there. But in reality, after 20 years of doing medicine, I came up, okay, thinking, okay, there has to be more than that. And I came up with this concept of disease triangles, which involves lipid system, immune system, microbes, and microbiome, and these two connected by our genes and epigenes. So I call this concept of disease triangle, and that's when things change. I decided to go and try to learn what's going on with healthcare, and understood that the whole metabolic health drives diseases, and non-communicable disease outcomes are related to how non-communicable disease influence the outcomes of infectious disease. So that was one of the things in 2009. There was when everything showed that infectious disease are down because of antibiotics and all the innovations. But in reality now, the new plague is infectious disease being down. There is a new plague, which is metabolic ill health. So unless I try to change myself, which I did with 50-pound weight loss, I was able to change my own LP little a level, which people are told that you cannot change your LP little a level. I reduced my LP little a level from 105 to 58 or 60. And so then I said, okay, now you cannot once you see the truth of what's going on, you cannot unsee it. And I try to prove myself wrong every time, but I'm being proven that this is the choice that really works for me and for every one of my patients, that I passionately sit down and encourage them to improve themselves.
Yeah, because I see that you once wrote that with LCHF, I changed myself and now I help my patients. And that's a very powerful one-sentence statement. And we should just explain for our viewers and listeners, LCHF is low carb, high fat in terms of dietary change. So it really seems that, and every guest that I speak to has a different way of going from the traditional teaching to the lights go on, and all of a sudden we realize, no, we weren't necessarily taught completely correctly, and this is the truth, the new truth, as it were, with metabolic health. And so for you, it seems that there was a family tragedy on the one hand, but also a personal experience for you. And that was, in a way, your epiphany, I'm thinking you're saying, and then
Yeah.
that led to the lights going on for you, and now you're trying to help your patients, which is wonderful.
Mm-hmm.
So you've also said, I know that you you don't think small, Ravi, you think big. And you just want to change the world. You want to change the health of the world. You want to remove barriers to healing across the world. You want to have that impact. And I
In
just think that's
reality,
wonderful. Yeah.
in reality, I want to change the world, but I know I can't. But I can only change myself. So I struggle with it, and yes, I mean I want to help others help themselves. I'm not in any thinking process where I think that I can change the world. I can be there for them when they are ready. It's like it's like when the student is ready, the teacher comes, kind of a thing, where if I'm able to be ready to help them and they come in, and at this point I'm trying to go out and trying to change it using different approaches, including a platform-based approach and different processes that I'm trying to use the knowledge that's God given to this time that I am allowed to stay on this earth.
Right. I think, can we just start by you explaining to our viewers and listeners diabetic ulcers, diabetic wounds, foot ulcers, etc. What are they? Why do they happen? Why do these things happen to diabetics at a very simple level?
I mean, uh, basically, uh, we have to also understand before that how much burden we are facing. Okay, like we have around $33 billion as a financial burden for US from wounds, just because of wounds. It could be $9.1 billion to $13 billion for diabetic wound from the US data, and venous ulcer is $14.9 billion, and pressure ulcer is almost $9 to $11 billion, and also burns is another aspect. So coming to the diabetic foot ulcers, obviously ulcers don't happen out of blue. And the question is, anytime there is pressure, nutrition, and vasculopathy and arteriopathy. So with hyperglycemia, we have problems with dysglycemia causing the atherosclerosis and blood supply that leads to neuropathy, and we don't feel. And the ravages of end user continuing to pressure the ulcer is causing. So normal wound healing happens, but on the top of it, it comes down to the things that I have on my back here. All these factors play into the process of clinical disease occurring, like dis-ease, lack of easiness. And basic simple process is that our blood sugar has to be in the range of 80 to 100. And when it is more than that, it's like our body is a sink, and when it cannot put together a certain amount of glucose and there is water floating around, we are harming ourselves, and that glucose that is excess is going and coating the nerves and the vessels, and then when there is no blood supply, then there's problems. So it's a multifactorial disease process, with the end user becoming a food addict and not understanding that their own problem is their food addiction, and their food environment has been changed. And the most harm that they do, even they understand, is where in their food environment, the home environment, and this addiction leads to many things. And so we are our own worst enemy.
Yeah, it sounds like you're describing a perfect storm with high blood glucose, and then we have people not being able, having neuropathy, so they can't feel what's going on in their feet, and they're eating the wrong stuff, and as you say, their own worst enemy. So it sounds catastrophic.
And also, we
Yeah.
have to understand the pathway to ulceration in lower extremities, and amputation goes to the foot at risk and ulcer starting, and then basically repetitive trauma, infection, ischemia. And now, on the process of this, because of this, there is ended up with, like, we ended up talk about this social determinants of health and all that, but also genetic determinants of health are going to be there. So when there is genetic determinants of health, and then on the top of it, the social determinants where you're not having access to the food that your system likes, and now you're hijacked away from it, from the real food that your system is made for. That's when the problems start happening.
Yeah, when we're not eating what we're adapted to eat.
Mhm.
I should just mention for our Canadian viewers and listeners, the numbers, the units that we use in Canada are different from the ones that are used in the USA. So when you say blood glucose should be 80 to 100, I think the conversion factor is 18. So we need to divide that in Canada by 18 to get the Canadian numbers.
Mhm.
But so I'm interested to know, we've explained why these things happen. How you found out that just the simple thing of trying to reduce blood glucose through diet, um, and that either through avoiding sugars, obvious sugars, or through avoiding starches and things that digest rapidly to sugar, that this would improve wound healing. Because I mean, I think that's the insight here. So how
Mhm.
did that epiphany or that insight come to you?
Basically commonsensical when we are I mean, like, it's, see, every day in and day out, when it's like AI inside of you to explain to it. It's like you're seeing this, you're seeing this, you're seeing this. I mean, like, and something is not right. When something is not right, you go seek, and there's the three things that I like to do in life is learn, grow, and give. And when you're learning and you're keeping an open mindset at not being in your own rabbit hole and be ready to be proven wrong, and which is what I, to this day, I'm not saying I have a solution for my patient. I'm saying that I'm giving them tools, techniques, and process. I tell them this one thing: it's not about fasting, feasting, or timing. In reality, it is about tracking. So low carb might not be good for you. This is what I say. Low carb might not be good for you, but how will you know that? Unless you implement it and make that impactful improvements and track it. So what I'm working hard is to provide them those tools and techniques and counseling, and be they trying to be there, wherein with that we're creating a platform that is able to be given to the patients. And we did some retrospective reviews on how we helped diabetic foot patients with low carb, that we did a small poster on. It's so hard to do this, being an active doctor, seeing like 60 patients a day kind of a thing.
Yeah, so it's all about tracking.
It's all
Um,
about tracking,
yeah, you
because
have to,
if you
and
don't
being
track,
able, yeah, being able to prove to yourself that what Dr. Kamepalli is telling me is true. So I think you're encouraging people to be skeptical, saying, just because I'm telling you this doesn't mean it's necessarily true. Let's try and prove it
yeah.
through the tracking. And then they've got the evidence as well. But I'd like to know, when I think of a diabetic foot ulcer, it's almost like it's a complication. It means things have been going wrong for some time. It's almost like an end stage thing,
Mhm.
advanced disease, in other words. But at that, what must be a relatively late stage, is there still hope for these patients that if they change their diet, even at this late stage, that there can be improvement?
Yeah. Hope in healing is what medical profession has to give to the patients. When they stop giving that hope, and they're not being the professionals that they are supposed to be. They should park their own feelings at the door when they walk into that room with that patient. And that's about it. And from understanding this whole, I try to analyze the patient, but also understand that for me, it is about wound care and cancer. So now you're talking wound care. Now I'm bringing cancer into this. And what I'm trying to tell you is that it's, for me, wounds are on one side, cancer is on the other side. How do I say that? Because both are on the either side of the same coin. That concept is not easily understood because it is very nuanced. And if you say in cancer, there is high the growth, there is increased growth, whereas in wound care, there is no growth in wounds. So we want to grow here, we want to not grow here. So they are on the opposite sides of that coin. So, I mean, if you look at the mechanisms, which is a very nuanced thing, and I rake my brain trying to figure that concept out, and which is what APTN, I had this idea where I wanted to create a separate channel in APTN for cancer and wound care. I wanted to be a part of the cancer thinking so that I understand what is going on with the cancer thinking, just flip it to look at the other side. So to your question, I want to tell you that I think of wounds like cancer for the other side. The reason why I say that is the 5-year mortality rate and the direct cost of diabetic foot ulcer beat breast cancer out of the park. So if you have a breast cancer, the 5-year mortality rate is 9%. Whereas for the patient with diabetic foot ulcer, it is 30%. And for even with minor amputation, the 5-year mortality rate at 46.2, and with a major amputation, the 5-year mortality rate is 56.6. So that disparity, that too much effort on cancer side is great. That's great. Okay. But what is being done for diabetic foot, or forget about diabetic foot, what is being done for metabolic ill health? Why are we not even thinking that disease processes are driven by metabolic fitness of each person at a time? We don't have data.
Yeah.
We don't have data.
Yeah, it all gets reduced to metabolic health and
Yeah.
insulin resistance and things like that. Yeah, that's the sort of the common denominator. But I'm interested to know how I mean, you're explaining this to me in a certain way now, but let's say you've got a patient with a diabetic foot or diabetic foot ulcer, and they're coming to you as a wound specialist, and would they maybe be a bit surprised to hear you launching into a discussion on diet? But how would you explain what they've got and what you want them to do? Can you just take me through that, please?
So have you ever heard about hitting the nail or hitting the iron when it is hot?
Yes.
Okay. So people are ready to receive when they are there. So I'm walking into the room telling them, you need to do low carb, you need to do keto. No, I try to understand them. I try to see where their family situation is. I try to talk to them and I address their main problem. Okay, I'm infected, fix me. I don't really bring up much of metabolic health during the in-hospital stay because in the hospital, they are there for a problem. Okay, so that needs address. But the issue is when they come to the office, they are a little bit more relaxed, but wanting to understand. By then, I give them my, like say, website, or they look me up and they know what I do, kind of a thing. And I encourage them to do that. And I said, we'll talk more when you come to the office. And when they're in the office, they just ask them, what are they doing and are they tolerating these antibiotics and whatever. And we need to clean out this dead devitalized tissue in the wound bed. And as I'm talking to them, I'm asking them, what are you eating? And then that opens up the thing, what they are doing. So everybody intuitively know that the sugar that they eat is bad for them. They know that. So then I did the analogy of the sink and the mop and turning off the tap. So, and then I have the sink right behind me they say, can you see behind me, there is a sink. And there is, imagine that the tap is off and I'm cutting and I'm taking care of the wound at the same time, but then I'm talking to them. So when I'm talking to them and they are, okay, paying attention, so they are thinking that I'm talking to them, but I'm taking care of the wound right as I'm doing it. So I have their discussion going and I don't implement anything. I say, just do few things, you're sugar loaded. Why don't we just cutting down the carbs a little bit, increase your protein, fill with good fats, and we'll talk. And take this app. This is free for you. And you track the pictures and it'll come to me and we'll decide. So I give them, so the advantage that I have is for a diabetic foot is they come to me every week. So I get this 6 to 8 weeks to 12 weeks of same thing hammering. If you see my X handle on the top, there is a hammer beating like that. Like I have this continual like a GIF that I have. I'm just doing that. That's what I do. And then they understand it. They finally give in, or they don't have to be 100% to help solve the wound. You see, you can just at least if they can go down 20% of what they do, that's okay.
Yeah, no, I've got this image of Dr. Kamepalli cleaning, debriding a wound, and at the same time talking to the patient. And it's obviously a wonderful opportunity
Yeah,
for learning. And you've got the almost the guaranteed follow-up because they have to come and see you
yeah.
8 weeks, 12 weeks, once a week. So you know this is just the first of many visits, and you can introduce it and then maybe follow up and get a bit more deeper into it. So do patients in general find your dietary advice easy to follow, or are there challenges? I guess they staring, losing a limb in the face, so they're probably quite receptive to these kind of thinkings.
Yeah, they are receptive, and I have had multiple patients receive and improve, but also once they are done, they are kind of lost, and they fall back, and they know that they are falling back, and on the people who are really I'm worried about, I try to even get back to them. I mean, you get this, you remember a patient sometimes and say, "Oh my God, what happened to him?" And I don't remember names, you see, because I'm culturally challenged. I don't remember names easily. Then I have to go back and ask my staff, hey, this and that, can you call that patient? Try to bring him in. Let's see what's going on. And sometimes, I tell them I'm not going to charge you, just come in. But then they don't even do that.
Mm.
Because now it's the foot is all healed up, and the addict kicks in. It's like a cocaine addict getting back to cocaine. I call this cart cocaine. Okay. So then it's like, I tell them, hey, you are lost from me, but I'm there for you.
Yeah, it's human nature, isn't it? When you're in trouble, you listen, and then we all like that. When things seem to be better, we go back to our old ways.
Mhm.
But can you give me some examples of sort of success stories of patients that come to mind for you that where you had a really good outcome as a result of these diet changes?
Yeah, I have multiple. They are on my YouTube channel, and what one of them comes is one of a patient who we had a charcot foot. Is a charcot foot is an arthropathic like neuropathic inflammatory changes in the charcot foot, where the foot goes like flat and then the bones are crumpling down. And this is a patient with an ulcer who was going to have amputation of the leg. So I was able to help her, and I'm still helping her. And um, basically, we were able to use the low carb approach, normalize her sugars, get her off insulin. And it's on my YouTube channel. And in fact, it was one of the patient who was featured on. I think Guardian article that was published showing that in most of the other patients that had this problems, they were sitting in a wheelchair, whereas this my patient was standing up and has a picture and all those. And then there are multiple of them where with osteomyelitis, with bone infection. So I have an advantage because I can understand the infection part. I can understand the wound debridement part. I can understand the metabolic part of where they are struggling, and then bring them together and explain it to them and be on their back saying, okay, you're not posting your pictures. I need your pictures. So it kind of I mean, like I literally enjoy it. Let me put it
Mm.
that way. And
Yeah.
and when you enjoy it, you glow in the time in the zone when you're there. It's like, for me, my staff asked me, why are you not going anywhere? You're not taking vacation. I said, I'm on vacation right now. So so it is For me, that makes me happy. That's all I can
Yeah, and if you found a niche where you are fulfilled and it's joyous work, it's very hard to replace that with anything else, because that's really what our lives are about. Just finding an area where we're good at what we do and we're happy doing what we're doing. But I wanted to ask you also, you've got this website called No Bad Bugs.
do.
Can you just explain what that means, please?
Yeah. So if you see the triangle in the back, okay. So number one, I want us see. I was trying to figure out what I was doing with myself in 2012, 13 time. Okay. In around 2008, I started 2007 and 8. I started doing fecal bacteriotherapy. Okay. So where I take patients who have C. difficile infection, and this C. difficile infection kind of kills a lot of patients, and with too much antibiotics when there is, and then there is C. diff growth. So I came across I went to one of the infectious disease conference, and they were doing fecal bacteriotherapy in Europe, and one of the guys presented it, and I bought it, and with my partner, I was able to get it into the protocol in the hospital. And we were doing fecal bacteriotherapy where we take another family member's stool, screen them for infections, and give them to the patient. And I chose a different path where we put a tube down the NG tube into the duodenum. So I was thinking, why am I successful? We had 98% success rate, and the data that I presented was in a poster was a chosen poster at Infectious Disease Society of America in 2013 ID Week conference. So I was thinking, what am I doing with are there bad bugs? Are there good bugs? And then went, and at the same time, I guess there was an article saying that there was MRSA in Antarctica when they dug deep down. So these bacteria have been here for a longer time, you see? And if they were bad, why are they there? Okay, this creation was created and they belong there. And we have a lot more bacteria than human cells. 90% of us really are bacteria. And obviously, we live in homeostasis. Okay. So when we are maintaining ourselves in that homeostasis, our diseases are not there. So what does it matter if a bug that is might be harmful to me is somewhere, only if I can fix myself? So I came up with this thinking, hey, how can I then make that an idea? I was trying to start a website, you see, and I needed a name that is unique. So I said, okay, and there was some thinking about bad bugs, no drugs during infectious disease thinking. So I said, okay, bad bugs, no drugs, no bad bugs. So boom. I just I just said let's and now if you think COVID is bad, it's a bad bug. But what did COVID do to us? It made us think more. I wrote this opinion piece in 2020 in the University of Louisville Respiratory Medicine Journal. You can look it up, augmentation of T cells with dietary approach. And basically, it is our immune system that has to be augmented. So when we have excess fat, our immune system goes there to get rid of that fat. So the T cells are not working. So bad bugs are there to do their thing. They have time to evolve. We cannot chase them. What we can do is chase our own thinking, our own understanding, and our own fat mass disease, which is lipotoxicity, which is leading to problems with abnormal lipid level that is causing all the fatty liver. So lots of fatty liver. How can people respond? So it's not the bugs that is more. Yes, bugs are important. We need to take care of them. We need to rebalance the bugs when they are causing bad problems. But when they are not, you leave them alone. You don't chase them. So that's the concept in my no bad bugs thinking on the top of this concept of disease triangle. So I'm trying to be a guy in my sandbox, enjoying my game. So trying to come up with my own thinking of how I can add to the healthcare improvements.
Sure. So if I can try and ask you a question on this, it's the same topic you're talking about, but I'm maybe just phrasing it in a slightly different way. But the bugs are there, they're all over the place. And why do some of us get sick and get infected and others of us do not? You've sort of hinted at it, but can you just explain that a little bit?
I mean, basically, let's take the common bug the people fear. Okay. The common bug people fear is MRSA. Okay. So MRSA has been there in Antarctica and when they deep drill down, and MRSA is there in the community, MRSA is there in the hospital. The reason why you need to isolate when people are in the hospital with MRSA is to prevent that MRSA moving from that patient to the another patient who is possibly is like this last straw on the camel's back. So now that patient is challenged already, and you throw this bacteria on them, it's like you're pouring more gas on the fire that that patient is going. So that is the idea of isolation process. So the goal of understanding the bacteria is controlling them, but also not neglecting the human aspect of it. Right now in healthcare, we go through this roller coaster of glycemic roller coaster every day. I mean, like I cringe when I see they have telemetry for EKGs in the hospital. We need to create a teleglucometry in the hospital, and that will impactfully change healthcare. All the CGMs that are available can be used to create a teleglucometry, which is what I want to do badly, but nobody is really working with me. If anybody is listening and want to help me do it, I'll be at their beck and call and we'll make it happen. I have tools, techniques, process, and also resources. From a patient perspective, there are patients that I can work with in the hospital system that I can set up with. But, I can keep talking, but, you get the idea.
Yeah, and I would imagine that we're closer than ever before to that vision because we've got CGMs now, continuous glucose monitors. So closer than ever. But so you've mentioned your advice to patients is let's just say it's low carb dietary advice. Do you actually progress beyond that to recommending ketogenic diets, or
Oh,
is low
yeah.
carb on itself good enough?
Yeah, no. I teach them about nutritional ketosis, therapeutic carbohydrate restriction. I help them track themselves. I use a glucose ketone meter, Keto Mojo, which is integrated into the platform that I have. I track their food. I teach them and I talk to them about their insulin levels. I do insulin testing on people. In fact, I do craft testing. And I've diagnosed a lot of patients with reactive hypoglycemia.
So, yeah, is it true then, am I understanding correctly, that ketosis is actually good for diabetic foot ulcers? I mean, being in ketosis actually in some way can promote healing. Am I understanding this correctly?
I mean, we need to do a lot more studies to prove
Yes.
that. But in my clinical experience, so what am I trying to do? I'm moving away from mass medicine mindset, which I call M3 medicine, to power of one, N equal to one medicine. I mean, what does medicine mean to anybody if it's not helping them? So the question is how we can use that patient's nutrition and put them into the state of nutritional ketosis, because ketones are magic molecules, anti-inflammatory molecules. If you're in the nutritional ketosis zone, okay, and basically 0.5 to 3 millimoles per deciliter, you are in the zone of nutritional ketosis. When the anti-inflammatory molecules are helping the patient in preventing the inflammation, what more does the patient need? And we already talk about I mean, like in cancer, they say, oh, don't eat sugar because that helps grow cancer. And we intuitively know that we should not eat more sugar because it increases neuropathy, arteriopathy, vasculopathy, everything. So we know that. So that is commonsensical. We are hybrid animals, you see. We are hybrid animals. We can use glucose, we can use ketones. When we use more glucose, we produce more reactive oxygen species. When we use ketones, that is, if you're in a state of nutritional ketosis, we are producing less reactive oxygen species. So it doesn't need any biological proof more than that to tell you that to be in a less inflammatory state, you have biologic basics to say that you're producing less reactive oxygen species if you don't eat carbs, and your body can survive because of the fat mass that you have. And all you have to do is not stimulate the insulin by eating carbs by 100% and eat protein that stimulates insulin but also stimulates glucagon and balances it out, and eat good fat for satiety. And commonsensically, this makes a huge sense. Now, everybody wants data. And the problem is the data is this bell curve. And what happens to the 2/3 people that are outside the bell curve? I mean, are they not people? The art of medicine is being hijacked away. We need to empower the end user. We need to use people, process, technology, not just preach, but help them track the data and create AI processes wherein AI agents for the patients can help them change them. That's what I'm trying to do.
Yeah, you certainly have a vision. There's no doubt about that. I just find when
Action.
I'm talking to like seniors groups, not colleagues, not physician colleagues, but potential patients, some of whom have got diabetes, some who don't. But when I mention ketones, there's still a lot of ignorance around. I've got to start explaining at very basic level what are ketones. It's not like I'm talking to people that right away know exactly what I'm talking about. We've got to actually, that's one of the messages, these two alternative energy sources, and why one seems to be preferable to the other, in particular for people with pre-diabetes or insulin resistance or type 2 diabetes. But I'm interested to know, Ravi, look, what you have been telling me for the last while, this is not something I was taught in medical school. It's new, it's novel to me. And I'm interested in the reactions of your colleagues to this. Is there general acceptance of what you're doing, gratitude for what you're doing, or is there some pushback from colleagues who say, oh, he's on the wrong track?
I've not faced any. I mean, they might be talking behind my back, but they already know that I'm a lost cause for them if they are, because they know that I am that. And I go through that from a learning perspective. I try to understand what they specialize in and try to share my knowledge that is specific to their specialty. So what I'm trying to build is a bridge on the silos of excellence. So how am I doing it? I have a WhatsApp group that I have 400 doctors that I am teaching low carb. So I have 3,000 doctors in India. That's a separate group, which I am a founding member of an organization called Indian Podiatry Association. So I'm teaching wound care to that 3,000 doctor group through WhatsApp. And the idea is simple, try to understand why your diabetic foot ulcers are happening. It is diabetic foot. So in 2008 and 9, when we founded that organization, I was a wound care doctor founding the organization. But as I evolved into this, now they look at me and say, I'm a metabolic doctor, not a wound care doctor, whereas I'm an infectious disease doctor in reality. So, it is an amazing thing. And if I'm talking to, say, a group of pulmonary doctors, which I have like an ICU group on a WhatsApp thing that I'm trying to teach, if I have some ketone basic thing, which I talk about microbiome as a lung microbiome. In fact, lung is a immune organ. So how microbiome, how the gut influences the lung, gut-brain axis, gut-skin axis, gut axis everywhere. So it is an amazing thing that we are able to see improvements in the neurological aspects with all this GBM data that is coming out. So only thing is, we just have to get to them. And I kind of in the past was on the wrong side of one of the big organizations. I left that place because I was trying to preach this low carb thing. So yeah, I mean, you get these hints where you don't know you're beyond your bounds, and you just if you're not belonging there, you get out and you do your thing. So I mean, I'm a guy who can never be an employee of another entity. So.
Yeah, no, I think I'm encouraged by what you're saying, that there isn't sort of direct pushback. Now, I'm just reminded of, I think it was Dr. Gary Fetka in Tasmania in Australia, who had maybe somewhat similar insights to yours, the value of reducing carbohydrate intake to prevent amputations. And as I remember, he had a lot of pushback from the authorities in Australia, but that was a while back. So I'm hoping that this is an indication that things are changing.
Yeah.
This is maybe not completely mainstream yet, but I hope that in a few years this becomes the new mainstream, because if you are seeing the results of what you are doing and you've got these success stories, I mean, it's very difficult, I think, for others to keep on ignoring it. I mean, the evidence is accumulating and it's there. And I'm encouraged also by your mention of almost like a community of practice. You've got these 3,000 people that you're educating and teaching, and there is a sort of a low carb community which is evolving around the world, really.
Yeah.
Here in Canada, it's IPTN, in Western Canada, in British Columbia. And I know you've referenced IPTN before in some of your other interviews, so you know about us. But it's a good feeling that there are these people in all the far corners of the world who kind of beginning to think the same way and realizing everything we were taught was not necessarily true.
I mean, I think the data for low carb was already there in early 1900s or late 1800s, and the execution of dietary improvements were there. There are studies to show that, and there are articles published in annals at that time. So, with whatever way in which this whole hijack of medicine was done, was very water under the rug, and that had become quote unquote mainstream. And that is what the problem is. So it's like we have been hoodwinked into making food not as medicine, but something else. Medicine, like, throw a medicine for a quick fix, because our mind wants quick fixes, you see. I mean, but the problem with this whole delivery of care involves doctors being independent. Okay. When they lose their independence, they cannot take care of the patients the right way. They might get the 15-minute visit out, but it affects them. And when it affects them, that means that their burnout starts. Okay. When the burnout starts of the clinician, the society is not valuing the time this person put in to learn the science, and now you employ them and make them your laborer with your own rules. So you're not trusting this guy who you have put in so much knowledge and not letting him be him. Yes, track. That's what I said. If any implementation you just track it. So there are things that I'm doing out of the box, and there is legal liabilities for it. But If you are tracking and showing that this is a good faith effort, the patient and the family is on board with it, and you're tracking and you're showing, then that case reports can come up and be reported, and that becomes standard of care.
Mhm.
It's
Yeah,
a truth, you see. When
yeah.
the truth keeps going, you're evolving, and truth is ever changing. Nobody owns science. Nobody, just because somebody stands on a bully pulpit and says, I am science, that means he's lost.
Yeah, no, I'm glad you've covered that because I was going to ask you about it. You've explained a little bit, extrapolated on this concept of hijacking, because I wanted to ask you about that. Um, yeah, so I mean, to me, ultimately, this takes me back to why I became a doctor in the first place. You know, wanting to actually help people and heal people, and not get involved in just more and more forms and more medications and more side effects and all these vicious cycles that develop. So some of our other guests have said this is happy medicine that we're doing here. And just being able to see the results in front of our eyes is really very empowering. But Ravi, just as a final question, just in wrapping up, I'd just love to hear if there are any sort of main tips, takeaway messages that you have either for our colleagues or for patients, if you just were to bring this all into a nutshell, any main tips that you've got?
I mean, believe in yourself, number one. Believing in that doesn't mean that giving up, and looking at yourself and thinking that, hey, I'm going to get the solution that I need. Hope is what we have to give our patients and everybody. They have to empower themselves, not give up, not be discouraged, not be disappointed, and seek, learn, grow, and give. And for the doctors who are out there who are struggling and burnout, I think it's time you declare the independence of being you. Take a little bit less home, no worries, because we did not come into this world with this money. We are not going to go out with this money. And just throw money at the solution that you want to see happen. You're going to fail. I lost my shirt on a few times, and I don't give up because number one, I think I know the truth and I'm seeking it. And if I'm wrong or if I'm failing, that's the lesson that I have to learn and use a team approach. Together everybody achieves more, and team approach is what we have to. I have to give a lot of my knowledge up to bring and work this platform system that I'm building it. So, I mean, you need to enjoy what you do, not from a drug addiction or a alcohol addiction standpoint. That's not enjoyment, that's pleasure. Okay. So let's create a medicine of enjoyment, move away from mass medicine mindset to power of one and equal to one approach. And hopefully if that is what I can convey. And you can look up, my X handle is at wound physician, and my hashtag that I've been using since 2014 and 15 is hashtag removing barriers to healing. I have a trademark on it. I don't know, nobody had it. So I applied for trademark and got it. It's called hashtag removing barriers to healing. So please.
Yeah, that's great. No, thank you. And so we'll put those in the show notes for our viewers to look at. So just trying to distill this: learn, grow, give. Um, Tracking is important, but above all, I think enjoying things.
Yeah.
I love the way you finished with enjoying, because it's so important. If we enjoy what we're doing, it spreads. It's infectious, to use
Yeah.
a bad term for you, maybe, but it's
Yeah.
infectious. When we
Very
enjoy what
infectious.
we're doing, it spreads. Yeah. Yeah. So Ravi, Dr. Kamepalli, thank you so much for making the time to speak to me today. I really, really appreciate it. It's been a joy chatting with you. I want to thank IPTN, the Institute for Personalized Therapeutic Nutrition,
Mhm.
for sponsoring this series. I want to thank RCCBC, the Rural Coordination Center for British Columbia, for inspiring me to do this work. I want to thank Anne Mullins, our producer. I want to thank Graham Wheeler, our technical whiz. And once again, you've been watching At the Helm. Thank you for joining me. I hope we can see you again. And thank you so much, Ravi Kamepalli. It's been
Thank
a
you.
joy talking to you. Thank you.